Thank you, Professor Kote, and thank you for such a generous introduction. And I would congratulate the organizing team for having made this possible here in Goa and getting us all together in this beautiful city and in this beautiful venue. I'm sure by the end of this conference, we will be richer in our knowledge about transplantation, and what is important is the key issues that have been picked up are the most pertinent issues, especially what to do with the elderly donors, what to do with the elderly recipients. So before this session, we had sessions on donors and we had some discussion on which donors to take, whether it is right to take elderly donors. And now I will be talking to you about the next session, which is about the recipients, elderly recipients. So before I start my presentation, may I have just a show of hands on how many of us have actually ended up doing recipients which are above 80 years of age? 70 plus, just one hand? 2, 3, 4, 5, 6, 7, 8, very nice. And 60 plus? Oh, that's very nice. So I think it's going to be easy for me to talk about and make the point very clear about what I want to say today. So today I'm going to talk to you about how we're going to select our recipients, what is this induction and maintenance therapy that is available, and what is the outcome of our patients that we are going to transplant. So before that, I think it's important for us to dig into the epidemiology and look at the number of people existing on this planet who are above 65 years of age. And there's a huge population, according to the US RDS data, as well as the Indian study, which says that we have a formidable amount of population which is above 65 years of age and is CKD, and all of this patient is going to go into dialysis or into transplantation. So when you're looking at the US RDS data and dig deep into it, you see about 33% of the patients who are CKD that were analyzed in the last decade are more than 65 years of age. And similar so, when you look at this data that came from the Banaras Hindu University, Varanasi, you see that as the age is going up, you will have more number of patients that are into CKD, and especially 40.6% who are 65 years or older. What exactly happens to these patients? So there's a very seminal paper that was published a couple of years back, which showed that most of these patients, even in the US, ended up doing dialysis, and very few of them actually ended into transplant because of obviously the waitlisting and enrollment into the waitlisting programs. And you see preemptive transplant, just a minimal 138 patients, which is actually quite a minimal decimal figure. So why is it that these patients are not getting transplanted? We understand that as the time is going by and the life expectancy is increasing, you will have more CKDs going into dialysis, but we also do understand that dialysis itself has a very high mortality rate for these patients. And as the age goes up, the mortality rate even becomes worse when you put these patients on dialysis with decimal figures of less than 25% survival after about 3 to 5 years of dialysis. And the most important feature of why these patients are actually not doing well is because of the fact that there's a cognitive decline, there's accidental falls, and these patients will experience virility, which is, you have different virility indexes, which very directly correlate with the outcomes of your patients and the mortality in your patients. So now we have some studies which are going to tell us that there is some survival advantage when you're transplanting these patients over dialysis. So what does it basically do? So you want to transplant your elderly gentleman in your house or in your family because you want to improve his quality of life, which seems to be published now that it does improve the quality of life. And you want to make him feel overall better, not send him to a dialysis center, and have a good social life. And I think all of this is taken care of when you transplant these patients. So in the end, now that if you've achieved all of this, what is the survival perspective in these patients? When you look at the US data, it shows very clearly, these are the best dialysis centers probably in the world, and still you can see very clearly that even up to the 3 years survival is about 50%. So when you're comparing a young patient, which is less than 45 years of age, and looking down to more than 75 years of age, you will see very clearly that the survival is actually going down in these patients. And this is a paper that was published by Dr. Tarun Jaloka in our country, and this was published about a decade back, which showed again the same feature, but the problem here is that the figures over there go down even further to just about 41% of your elderly patients surviving as compared to 96% of your patients surviving at 24 months. But most of the patients in his study were more than 70 years of age. So what is the option that we have for improving these outcomes? Obviously, we're looking at transplantation today. And who is going to be an appropriate candidate? We can discuss this towards the end of my discussion over here. So I think age should not be a barrier, and you should be carefully be selecting the population that you're going to transplant, especially the elderly population. You should screen them very well, especially for the presence of cardiovascular disease, cancers, and also most important is also see what his social backing is, whether after the transplantation, the family is going to actually be able to back his transplantation medicines and whether he's going to adhere to his medications. And for that, you do have some scales which can actually predict what is going to be the comorbidity of your patient, and you can use these different scales and predict what the outcomes of your patient are. And they have been shown very clearly that if you have these scales predicting good outcomes, you can have more than 65% survival at the end of 3 years in patients whom these scales have been used. Apart from that, assessing the frailty index is very important. As I said before, that most of the frailty index scores directly correlate with the overall outcomes as well as survival of these patients. You should also be looking at the psychosocial as well as the adherence of these patients, and we understand that most of these patients are going to have a lot of cognitive decline. So it's not just looking at the graph, not looking at his survival, but also looking at the cognition of this patient, whether he's going to actually survive the transplant throughout and have a very good cognitive activity. And most important is when you're transplanting, you should also know whether your team is adequate enough to do a transplant of an elderly gentleman who's going to be having calcified vessels, and so they should be able to transplant them very well. So there are different scales that I was talking about. You have medication compliance scales, which will predict whether your patient is going to be compliant to your medication or not, and also whether there is an adherence within the family itself towards the outcomes that take place after the transplantation. Having said that, I think the most important thing here is to understand the semantics of the entire situation and looking at what exactly is going on in this elderly gentleman that you're going to transplant. It's going to be two basic things. There is a concept called as the immunosenescence. So what happens in immunosenescence is as the patients carry on with their life, you have more number of memory T cells and you have decrease in the native T cells. What that basically means is that you're going to be having less immunoreactivity to any kind of antigen that is presented to you. So that could work in your favor and that could be against your favor too. It works in your favor because you could get away with low immunosuppression without the risk of florid rejection. But at the end, if you give them more immunosuppression, thinking of more that they have more chance of rejection, they can also have more infections. So there's a very thin line which is very difficult to understand, and we'll talk about how we can do that maybe in the future in the later part of my slides. Apart from that, most of these patients are also obese, so you will have a lot of adipose tissues in these patients. Because of that, you're going to be having a lot of your drug which does not go into the main circulation, and so it's going to be difficult to achieve levels of your patients. And at the same time, you can also have, you will see very decreased activity of the of the cytochrome pathway, that is the PG450. So you will have lesser amount of drug that is required in the circulation because the metabolism is not going to take place. So in the end, what you have to basically decide is between high immunosuppression, more infections, and less immunosuppression, more rejections. So it becomes a very complicated feature here. So what are you going to use in your patients? So obviously the dictum is to reduce the immunosuppression. As we know for all our patients, the standard protocols which are used all over the world is a CNI combined with an antimetabolite and obviously a steroid. But what do you do for induction? It is always preferable, if possible, as much as possible, to use lower potency induction agents, especially the IL-2 receptor antibodies, that is basiliximab. ATG has been used in patients in which people have tried to take these patients off CNI or off steroids, but the outcomes have not been shown to be favorable towards using such kind of a combination in terms of death-censored graft survival, improving death-censored graft survival. So the maintenance regimens primarily all over the world appear to be at least a CNI and an antimetabolite. Steroid free protocols have been used by a lot of centers, and because that's to reduce the cancers, the PTLD, and the fractures in your patients. So less immunosuppression, the better. And CNI avoidance has been done before, like I've spoken to you before, along with the use of ATG, but these centers have seen and reported a very high rate of acute rejections. CNI withdrawal is also a good concept that was brought about in the late 2000s, but then it was not successful because there was a higher risk of rejection in these patients, and especially if you had epitope mismatches of more than 11, which has been proved in a recent paper that was published about 5 years back, you have a higher chance in these patients, and so you can modulate your immunosuppression depending on the epitope mismatch. What has to be avoided is probably cyclosporin, because the data is not in favor of cyclosporin. For some reason, cyclosporin doesn't appear to be a good drug for elderly transplants. Now, this is just published data, but we have seen our patients in our center coming to us after many, many years of transplantation, and they're on cyclosporin, and these are patients who are now moved into the elderly groups. So it is difficult for us to understand why cyclosporin has been reported to have an increased risk of graft loss in these patients. mTOR inhibitor, though they have lower viral infections, but overall published data has told us that there is higher mortality when you use mTOR inhibitors. But when you're looking at and dig deep into the Transform trial and the Senator trial, in which what they've done is that they've tried to isolate a subgroup of patients in which they've compared CNI versus MMF versus CNI versus everolimus, they found that the latter part, that the CNI plus everolimus, which is obviously going to be a slightly lower immunosuppression, is non-inferior in terms of biopsy-proven acute rejections. And similar so even in the Senator trial, in which either when they converted from CNI to everolimus along with MMF, they found that there was non-inferiority in terms of biopsy-proven acute rejection. So that brings to one of the papers that we published just about 6 years back from my center, in which we tried to analyze. We enrolled about 1,150 patients, and we grouped them into two parts, that is aged more than 60 years. We didn't keep the cutoff of 65. We took 60 years, and then the second group was 18 to 60 years, which was the younger group. We followed them up from the date of transplantation to about 5 years post-transplant or until death of the patients. So the immunosuppressive protocol that we use is primarily the same as is used everywhere, as is used for the young adults as well as the old adults. They receive the same standard protocols, and donor evaluation as per standard donor guidelines, as well as the recipient analysis. So outcome at 5 years, we looked at the primary outcome, which was the death-censored graft survival and the patient survival, which was the primal and optimal point at the end point of our study. And the secondary outcomes, such as the biopsy-proven acute rejections, we are looking at surgical complications, risk of PTDM, and infections and malignancies. All of our patients that we enrolled, that is, in group 1, all of them essentially had to undergo a coronary angiography, and the ones that did not undergo coronary angiography were excluded from the study. And what we saw in the post-transplant outcomes was that you found almost similar acute rejection rates in either the younger group or as well as the older group. And when we're looking at the complications following your kidney transplantation, and looking at the p-values, look at the p-value which is significant is mostly the surgical complications and obviously the infections. And this is what is predicted mostly in most of the other papers too, that there is higher risk of UTIs, higher risk of pneumonias. Apart from that, you have surgical complications which we had graded using the Clevin-Dindo grading system, and we found that this group of patients, that is the elderly people, did have more number of hemorrhages, lymphoceles, as well as other complications. But when we looked at the grading, the grade was very, very low for most of these complications. In the end, we also looked at the primal point, which was the death-censored graft survival as well as patient survival. And at the end of 1 year, the data showed that the patients were doing very well. But when you look at 5 years, you see that there seems to be a difference in the overall outcomes of these patients when you compare them with the younger population. However, the p-value was not significant to the point that we had a smaller subgroup, so maybe that was the reason. But on multivariate analysis of the mortality risk factors that we were analyzing in our study, we found that diabetes appeared to be the most consistent factor which was associated with an increased risk of mortality. Apart from that, there have been some more studies which have been published from the Middle East, And this looked at about 158 patients, in which most of these patients received live donors, and they reported very high graft survival rates as well as patient survival rate, which was much beyond what was published in other studies. Now this is, we're missing Professor George Abraham here. He was a part of the study group which reported their outcomes from the South India. And when they looked at about 225 patients who underwent renal transplantation, especially living donors, and there were two groups. One was the elderly group, one was the aged 40 to 60 group, which was group A, and the other was group B, which is 60 years and above. When they looked at the cumulative graft survival, they were similar across both the groups. And that is what we found in the initial part, which was at the 1 year mark. But when you're looking later on at 3 years, 5 years, 7 years, there is obviously a decline in overall outcomes. In terms of acute rejection, the rate of biopsy-proven acute rejection was higher in the patients who were in the younger age group for reasons that we have already discussed before. And mortality rate also, in group B, they had a higher mortality rate probably because of advanced age and other factors such as infections and cardiovascular complications. So then, ladies and gentlemen, when you're supposed to look at how do we compare the outcomes for dialysis versus transplantation in the age group that we are discussing, we do understand from all the data that is presented till now that probably there is some survival benefit as compared with transplantation as compared to dialysis. And we know for sure that dialysis has not very good outcomes in terms of overall survival of the patient and social well-being of the patients. One of the last slide that I want to show what has happened over the last decade or so. When you look at the different years in which these publications have been done, you will see very consistently that the age for accepting donors is going up and up and up. So you have data now for as much as even 80 years. So that's the reason why I first requested a show of hands for 80 years, 70 years. So look at the survival, which has been the 2-year graft survival as well as the patient survival, which is to the tune of 60 to 70%, even up to 5 years post-transplantation. So I think that is much higher than the figures that we have for patients who are either on dialysis, especially in India, or even in the West. So sorry for this slide, this is it's moved up a little, but all I want to tell you is that in the end, what is important is that we have enough studies now from our country too, which have shown, even from the south of India, from the middle part of India, from the northern part of India, which are showing consistently that when you're looking at as high as even 7-year patient survival and graft survival, you can reach up to a figure of about 25 to 30%. This is a small cartoon which I propose in the end, from the end of my discussion here, which shows very clearly the gentleman which is on the first gentleman. He's got his kidneys all marked out, and he's got immunosenescence and frailty. I propose that we should have some biomarkers which should be used along with the indices that we use for selecting our donor kidneys, and have some amount of a protocol that can tell us that using the biomarkers and the frailty index, we're able to incorporate both and have a personalized immunotherapy per patient. So each patient has his own immunotherapy, and obviously to follow up whether the immunotherapy is not going to take him to the worst part of, that is the PTLD or to infections, you should be having some more biomarkers that can predict how you should do it, how you can take it up and down. So I would like to wrap up by saying that kidney transplantation is favorable in elderly patients with ESRD because it offers better survival and quality of life. And also, we know that most of the grafts that we are losing right now are not because of the problem within the graft itself in these patients. So death with functioning grafts is actually much lower than the loss of grafts that you're having when you're censoring the death. So, and in the end, immunosenescence is a concept that we should use in our practice when you're transplanting these patients, and most of these patients will require less potent immunosuppression, and that's the way I think it should go in the future. Thank you very much for your patient listening, and I think we can have some discussions.